Hi everybody, Dr. Mike here. In this video, we're taking a look at blood pressure drugs, having a look at what are they and what do they do. So, best place to begin is with the ABCD of BP. Okay, I've drawn up ABCD. This is the easiest way to remember the different types of antihypertensive medications, or generally termed blood pressure drugs. So to begin with A, there's actually two types of blood pressure drugs here that we need to talk about. First of which is going to be the angiotensin converting enzyme inhibitors, also known as ACE inhibitors. The second type that sits under A is the angiotensin II receptor blockers, known as the ARBs. Now you may see here that both have angiotensin in the name. They both work in the same pathway, just at different phases. We'll talk about that when we look at mechanism of action. The next type is going to begin with B. These are going to be the beta blockers. For C, we're looking at the calcium channel blockers. And for D, we're taking a look at the diuretics, specifically the thiazide and thiazide-like diuretics. Now, when you have a look at these particular types of classes of drugs or drug therapies, often the suffix, the very end of the drug, has a particular word associated with it, which can help you remember each class. So for example, when we look at the ACE inhibitors, they're often termed the prils. The angiotensin II receptor blockers are often called the sartans. The beta blockers are often referred to as the lols. The calcium channel blockers, they're often referred to as the dipines or pines. And the diuretics, and here we're referring to the thiazide and thiazide-like, a bit more tricky. Often they may have thiazide at the end, but sometimes they don't. But let's just pop thiazide as the suffix here. Now, when it comes to choosing which of these antihypertensive therapies should be used, well, generally speaking, of all of these, a couple of them are referred to as first-line therapies. That includes those associated with the A's, those associated with the C's, and those associated with the D's. So that means that beta blockers aren't generally referred to as first-line therapies for hypertension, so people who have chronically elevated blood pressure. Why is this the case? Well, it's because this large clinical trial showed that beta blockers were less effective at protecting people specifically over, or more generally speaking, people over the age of 60. They were less protective when it came to protecting them against things like stroke and all-cause mortality. So these particular classes tend to be those that are used as first-line therapy. Now, some of them can be used in isolation, so it's a monotherapy. Sometimes they can be used in combination. In order to understand why one would be used over another, we need to have a look at their mechanism of action. How do they work? So let's start with the A. Both of these, angiotensin converting enzyme inhibitors and angiotensin II receptor blockers, they work in the same pathway, which is pretty easy for us to understand. And that pathway is that of the Renin angiotensin aldosterone system. Sometimes just referred to as the RAS. Now, importantly, this system kicks into play when your blood pressure drops. Now, in actual fact, it's regulated by the kidneys. And I often say to my students, why would the kidneys control our blood pressure? And it's because the kidneys require huge amounts of blood every single day because it filters that blood. If it doesn't receive the appropriate amount, our blood doesn't get filtered, which means it doesn't get cleaned. And that means we start to accumulate metabolic byproducts, we get sick. It's not a good thing. So the kidneys require huge amounts of blood. Now I want you to think about this. Before we jump into that, you must remember the blood pressure equation, particularly when we're trying to see about how all these different classes of drug therapies work. Remember, the blood pressure equation is this. Blood pressure equals cardiac output times systemic vascular resistance. Remember that cardiac output is our heart rate multiplied by our stroke volume. What does that mean? So think about it. Your heart rate is around 70 beats per minute. It beats 70 times per minute. Now, with every beat, blood's going to be squirted out. Squirt, squirt, squirt. That's the stroke volume. So heart rate, how many beats, times the stroke volume, how much blood's ejected with every beat, gives you the cardiac output, which is how much blood is ejected from our heart every minute. So generally speaking, that's around about 5 litres per minute is our cardiac output. Now, systemic vascular resistance is simply the resistance in the vessel, meaning how hard is it for the blood to move through that vessel. If the blood vessel is narrow, it's really hard to move through, so the resistance is high and the blood backs up into the heart. The heart then needs to contract harder to overcome that pressure and the blood pressure goes up. So the things that can play around with systemic vascular resistance include diameter of a blood vessel and how thick that blood is, also known as the viscosity, right? Now over here, back at cardiac output, a couple of things can affect heart rate. Well, one main thing, the sympathetic nervous system tells the heart to speed up. You inhibit it, slows down. Tell the heart to speed up when you stimulate it. Stroke volume, how much blood is ejected with every beat. What can affect that? Well, the volume of the blood circulating in the body, that can affect it, and the volume of blood re-entering the heart, but also the contractility of the heart. How hard does it contract? So what we've just drawn up here, in actual fact, are all the different factors that can affect blood pressure. Think about it. If you increase the sympathetic nervous system, you increase heart rate, increase cardiac output, increase blood pressure. Increase the volume circulating in the body, increases stroke volume, increases cardiac output, increases blood pressure. Increase the contractility, increase stroke volume, increase cardiac output, increase blood pressure. Systemic vascular resistance, anything that you do to increase resistance increases blood pressure. That may mean constricting the blood vessel and decreasing the diameter, or increasing how thick the blood is. It's harder for things to move through. All of these different types of blood pressure medications play around with one or more of these different phases, and that's what we're looking at. So let's go back to RAS, back to the renin, angiotensin, aldosterone system, and see how the A's fit in. Let's look at the kidneys. Remember that your kidneys, its filtration unit is called a nephron. And there is blood entering this nephron through something called an afferent arteriole. If it's an arteriole, it tells you there's huge amounts of smooth muscle present, so its diameter can change. Then here's the glomerulus. This is where things get filtered. And then this is the efferent arteriole where the blood leaves the nephron. So you're going to have the proximal convoluted tubule, you're going to have the descending limb, ascending limb of the loop of Henle, and then you're going to have the distal convoluted tubule, what we call the DCT. All right, think about this. The kidneys, every single minute, wants to steal 20% of that 5 litres of blood. So 1 litre per minute must travel to the kidneys to be filtered. 1 litre per minute. Now, if this 1 litre drops, that means that cardiac output has dropped, which means that this has dropped. Now, if this has dropped, blood pressure has dropped. So that's why the kidneys are one of the major sensors for long-term blood pressure, is because if the volume of blood going to it drops, it thinks cardiac output has dropped, which means it thinks blood pressure has dropped, and its job is to increase both of those two things. How does it do it? Let's take a look. So let's say it's dropped. Let's say it's gone to half a litre. As it moves through, remember, blood pressure is the force that the blood puts on the walls of these vessels. If that has dropped, there are sensors, baroreceptors, pressure sensors in the walls of the afferent arteriole. These are specific types of cells that we call granular cells. Granular. And these granular cells, when stimulated by low blood pressure or low blood volume, stimulates the release of something called renin, the first part of the renin-angiotensin-aldosterone system. So a drop in blood pressure or blood volume can do this in the afferent arteriole going into the kidney or going into the nephron to be filtered. But there's another thing that can stimulate the release of renin. What? If the blood pressure is low, it's moving through more slowly. As it gets to the nephron, it filters with less force, which means the fluid that moves through these tubules moves through more slowly, which means there's a greater time, or at least greater time frame for things to be reabsorbed or thrown back into the body. Which means by the time the fluid reaches the distal convoluted tubule, all the sodium will have been thrown back into the body, right? Because it's had heaps of time to reabsorb it. So if the sodium concentration here is really low, it gets picked up by cells present in the distal convoluted tubule. They're called macular denser cells. Think of the denser for density. It's measuring the density of sodium. If sodium is dropped here, it picks it up. Now, what does it do? It speaks to the granular cells, because you can see the afferent arteriole and the distal convoluted tubule are so tightly, intimately related here with some tissue connecting. So, macular denser tell granular to release renin. Finally, another way to release renin is by stimulating the sympathetic nervous system. Once renin is released, it comes across circulating angiotensinogen. So the liver will actually make angiotensinogen. Angiotensinogen. Think about that name. Angio, blood vessel. Tensin, pressure. Blood vessel pressure. Has to do with managing blood pressure. If it ends in OGEN, it means it's stored and inactive, it's not doing anything. So what do we need to do? Renin comes along and chops it. Chops off that OGEN. What do we then have? Angiotensin. Specifically something called angiotensin 1. And it doesn't do much. At least it's not clinically relevant. But angiotensin 1 needs to turn into something called angiotensin 2. And it does this through an enzyme called ACE. Now the thing is, ACE, which is angiotensin converting enzyme, where does that come from? Well, mostly it's synthesized in the lungs. Oh, interesting. So once it comes across the lungs and ACE is released, triggers angiotensin 2 to be produced. Now angiotensin 2 will bind to angiotensin 2 specific receptors. And these receptors are located throughout the body, and specifically it tells it to do a couple of things. One, it is a vasoconstrictor. It constricts blood vessels. What does that mean? Think about this. You constrict blood vessels, you play around with their diameter. It's harder for blood to move through. Resistance goes up. Systemic vascular resistance goes up. Blood pressure goes up. Beautiful. That's what we wanted. The stimulus was a drop in blood pressure. It's homeostasis, negative feedback. The outcome, increase in blood pressure. Angiotensin 2 does a couple of other things. It travels to the adrenal glands on the kidneys to release aldosterone. Aldosterone travels to this distal convoluted tubule, tells the sodium in the tubule to go back into the body, and wherever sodium goes, water follows. Why? Remember, sodium has a charge, right? Sodium has a positive charge. Water, which is this boomerang-shaped molecule, the hydrogens have a slight positive, water has a slight negative, which means it loves charged stuff. So the water will follow the sodium wherever it goes. If water gets thrown back into the body, the blood volume goes up. If blood volume goes up, stroke volume goes up, cardiac output goes up, blood pressure goes up. Awesome. What else? Angiotensin 2 stimulates at the hypothalamus the release of ADH, antidiuretic hormone. What does ADH do? Travels to the distal convoluted tubule, similar to aldosterone, but instead of throwing sodium back, it just bypasses that and just throws that water straight back in. Again, increasing blood volume, increasing cardiac output, increasing blood pressure. Awesome. So you can see the importance of angiotensin 2 here in increasing blood pressure, and also the importance of ACE in this process. Therefore, when we look at angiotensin converting enzyme ACE inhibitors, if we inhibit ACE at this point, we don't go from angiotensin 1 to angiotensin 2. We don't get any of those things happening. And angiotensin 1 doesn't do much. Therefore, we can mitigate blood pressure increases. Great. What about angiotensin II receptor blockers? If we block angiotensin II receptors at all these tissues, the blood vessels, the adrenal glands, the hypothalamus, we stop them from working. Blood pressure does not increase. Beautiful. Therefore, these two A's help drop blood pressure. Okay, let's now take a look at the beta blockers. How do the beta blockers work? Let's draw up two things, the brain and the heart. There's the brain. Let's have the brain stem and the spinal cord. And let's just draw in the cerebellum for fun. And let's have the heart. Let's put the heart over here. And remember that the heart has the conduction system, which sends the electrical current through, and the myocardium, the muscle to tell it to contract. Part of the conduction system is the SA node, the AV node, and the myocardium, which is the thick muscle wall. Now, coming from the brain, if you stimulate the sympathetic nervous system, it's going to send signals down from the brain, and sympathetic neurons can come along and stimulate the SA node and AV node. How? By releasing catecholamines like noradrenaline. It can also stimulate the myocardium, the heart muscle, again, by releasing noradrenaline, increasing the contractile force. Now, it does this because the noradrenaline binds to adrenaline-specific receptors called adrenergic receptors. There are a couple of different types. You've got alpha receptors and beta receptors. And you can have alpha 1 and beta 1, and you can have alpha 2 and beta 2. Now, there's also beta 3, which are found on fat cells, not clinically relevant, so let's just focus on these two. If you take this adrenaline and throw it at these receptors, it's going to stimulate a sympathetic response, a fight or flight response, right? Think about anything that makes you scared or frightened. How does your body respond? It's because adrenaline's thrown onto one or more of these particular receptors. Now, you can stimulate a stress response either by telling a certain structure to do its job or by inhibiting a certain structure from doing its job. And that's how these different receptors can be separated. If you throw noradrenaline alpha 1 and beta 1, it stimulates that tissue to do its job. If you throw noradrenaline at these two, it inhibits the tissue from doing its job. And you might be thinking, wait a minute, how can I stimulate a stress response if I'm inhibiting a structure from doing something? Think about this example. We've got our lungs. We've got our airways specifically of our lungs. Pretty dodgy lungs, but that's okay. The airways have beta 2 receptors on them, beta 2. Now think about it. You're in a fight or flight response. It's stressed. Someone's coming at you with a knife. Do you want your airways to open up to get more air in, or do you want them to constrict to limit the amount of air? You want them to open up, get air in. That's a passive response. Airways open up because it tells muscles to relax, not telling muscles to constrict. So it tells the tissue to be inhibited, relaxing and opening up. Inhibition, right? Throw noradrenaline at beta 2, it relaxes and opens up. Now this is different to beta 1, which is found at the heart. Beta 1 is found at the SA node, at the AV node, and at the myocardium. So throwing noradrenaline here stimulates them to do their job. If it's the SA node and AV node, it's sending faster signals. So the heart rate goes up. I rubbed out the blood pressure equation. Let's draw it back up quickly. So if you stimulate through noradrenaline at the beta 1 receptors, increases the conduction, increases the speed of the contraction, increases heart rate. If you increase heart rate, you increase cardiac output, increasing blood pressure, stimulating the sympathetic nervous system. Again, here at the myocardium, increasing the beta 1, the noradrenaline at the beta 1, increases the contractile force, increases contractility, increases stroke volume, increases cardiac output, increases blood pressure. That's how these particular drugs work. That's the beta blockers. Calcium channel blockers, how do they work? Well, think about this. If calcium jumps into an excitable tissue, now an excitable tissue may be nervous tissue, muscle tissue, hormone-based tissue, so glandular tissue. If calcium jumps into those cells, it stimulates those cells to do what they need to do. So for neurons, sending a signal. For muscles, it's contraction. So similar to this beta-1 here, in actual fact, if you stimulate beta-1, you're going to stimulate calcium jumping in. So calcium channel blockers, well, it's going to do a similar job to here, right? Slowing down conduction, slowing down contractile force. But in actual fact, there's a couple of calcium channel blockers can come in two major types. The dihydropyridines and the non-dihydropyridines. The dihydropyridines are probably the most commonly used calcium channel blockers for hypertension, and they do work here at the heart, right? But there are the non-dihydropyridines, and they work at the vascular smooth muscle. Remember, arterioles have heaps of smooth muscle lining their walls. And if you throw calcium in, it tells them to contract. If they contract, they narrow. If they narrow the diameter, you increase systemic vascular resistance, increasing blood pressure. Therefore, the non-dihydropyridines, they work by blocking the influx of calcium at the smooth muscle, blocking that. Therefore, the muscles by default, like we spoke about here, they relax and open up. If you open up the diameter, you decrease the resistance, decreasing blood pressure. Beautiful. All right, finally, we need to take a look at the thiazide and thiazide-like diuretics. How do they decrease blood pressure? So we need to go back to the kidneys. We need to go back to specifically the nephron. And we've got the proximal convoluted tubule, we've got the loop of Henle, and we're focusing again on the distal convoluted tubule. And the cells of the distal, I'm going to really make that a big cell of a distal convoluted tubule. And then next to that, you're going to have those blood vessels that we're referring to, remember? So you've got the afferent arteriole, glomerulus, efferent arteriole. And again, make it really big. Now, an important point you must remember is that if anything, this is the distal convoluted tubule. Whatever remains in the tubule should be recognized as being outside the body. Whatever remains in the blood vessel should be recognized as remaining inside the body. So, think about this. You filter all this stuff from your blood. A lot of them are ions like sodium and chloride and calcium, right? Now, most of them get reabsorbed back into the body, inside, so back into the blood vessel. So it goes from the tubules to the cells of the tubules to inside the blood vessel. Now, on all of these cells, whether it's the distal convoluted tubule cells or the proximal or whatever, doesn't matter, embedded in the membrane here, you've got sodium-potassium pumps. And their job is to take whatever sodium is inside this cell and chuck it back into the body, and to take whatever potassium is inside the body and throw it back into the cell. Right? Cool. But that means that when it does this, that this cell is pretty much empty of sodium, which means there's a gradient now, and this sodium wants to go down that gradient. So the sodium moves down its gradient, which is fine, because now the sodium-potassium pump can take the sodium and chuck it out back into the body. Cool. But piggybacking on this sodium coming in is actually chloride. So this chloride will come in, and the chloride will just move through its own channel to go back into the body. Easy. Now, think about this. You've got calcium. Calcium moves through its own channel to go back into these cells, and then calcium will move from here to go back into the body. But calcium will only do this at the distal convoluted tubule if it swaps it for sodium. And again, that's fine because there's heaps of sodium in here and the sodium can just be thrown back in. So this is a perfect way to actually take chloride, bring it all the way back into here to be reabsorbed, take sodium, bring it back into here to be reabsorbed, and take calcium to bring it back into the body and be reabsorbed. But if we take our thiazide and thiazide-like diuretics, they work by blocking this sodium chloride channel. All right, they block the sodium chloride channel. What does that now mean? Well, it means that chloride and sodium stay here, and then they come out in our pee. And because they're ions and they have a charge, it pulls water with it, dropping the volume of our blood, dropping stroke volume, dropping blood pressure. Okay, that's the point there. But think about this now. Calcium still moves from here to here into the cell. But in order to go from here to here, it needs to take sodium. It needs to swap it with sodium. So it does that. It takes the sodium from our blood, whatever's remaining, and throws it back in. Which means that this sodium-potassium pump needs to keep going. And as it keeps going, it keeps exchanging calcium. So this sodium-potassium pump continually works really, really hard because these two are working in collaboration with each other. And so what we end up getting is that sodium-potassium pump works so hard to try and get the sodium required for the calcium is that the amount of calcium increases in the body because it just keeps pumping it out. And importantly here, the amount of potassium that we keep throwing in has to travel back here because there's a concentration gradient. So we pee potassium out as well. So that means that people who take the thiazide-like diuretics, they can have a couple of things. Apart from dropping blood volume, because all these ions are moving out, calcium increases in the body. Calcium increases in the body, which means thiazide-like diuretics, they may be the choice of antihypertensive for people with osteoporosis. Because that's a disease of not enough calcium being deposited into the bone. But also a side effect is we lose too much potassium and people can get hypokalemia. So they're just two considerations that need to be made. But what we've gone through today is the blood pressure equation, the ABCD of BP, what they are, how you can recognize those medications and their mechanism of action. So I hope you enjoyed this video. Hi everyone, Dr. Mike here. If you enjoyed this video, please hit like and subscribe. We've got hundreds of others just like this. If you want to contact us, please do so on social media. We are on Instagram, Twitter, and TikTok at Dr. Mike Todorovic, at DrMikeTodorovic. Speak to you soon.